Welcome to the webcast Wound Assessment. This program is sponsored by North American Center for Continuing Medical Education and is supported by an educational grant from KCI. My name is Susie Seaman. I am a family nurse practitioner and certified wound ostomy continence nurse. I run a wound clinic for Sharp-Reed-Sealy Medical Group in San Diego, and I will be your presenter today. Please note that all faculty disclosures for this program are located on the activity landing page. My goal in speaking to you today is to briefly discuss how to take a history, then review aspects of a thorough assessment of the patient and wound. I will describe the presentation of various types of ulcers, focusing on keys to differentiate between these ulcers to arrive at an accurate wound diagnosis. Please remember that to receive continuing education credit following the conclusion of this activity, each participant must complete the post-test and evaluation, which can be easily completed online for immediate receipt of credit at www.NACCME.com. Thank you for joining us. So I think the first thing we have to talk about is we need to make the point that a thorough assessment of the patient and the wound leads to an accurate diagnosis of the wound etiology and also identifies potential factors that may interfere with wound healing. This is critical because this will then result in an appropriate treatment aimed at optimizing wound healing. So there are key assessment points to obtain this correct diagnosis, and we'll be going through each one of these today. First, you want to take a thorough history, and then you want to assess arterial flow and look for signs of venous disease in patients that present with leg ulcers. You want to note the patient's general mobility as well as range of motion of any affected joints. You want to check sensation, and then lastly, you want to look at the wound. So let's start with the patient history. This is an absolute essential component of an accurate diagnosis. This is where you're going to do your early detective work, where you're going to be looking at the patient globally. We don't just look at the wound. We need to, again, look at what factors in the patient's medical history might have contributed to the wound or might be contributing to impaired healing. So I always tell people, talk to the patient first, look at the wound last. Our inclination when we see a patient, no matter what setting we work in, is to, for me, I'm in the outpatient setting, you walk into the exam room and you want to look at that wound. But again, I don't want to get any preconceived notions as to what's wrong with this patient. I've got to spend some time talking to them about how this wound started and what has worked and what hasn't worked in terms of trying to get it healed. So in terms of the patient history, there are some key points. The first is the chief complaint. And this is just what the patient has presented to you for. For instance, I have a non-healing wound on my left leg. The next part is the history of present illness. And this is where you are specifically asking questions about the wound. Not anything else about history. We're focusing on the wound. So for instance, how did the wound start? What was the cause, if the patient knows? Do they remember bumping their leg 3 months ago and the wound hasn't healed? Or maybe the wound started as a bruise or a callus or a rash and then developed over time. You also want to ask about current and past treatments, things like compression therapy, like use of stockings or Velcro devices or pumps. What kind of shoes do they wear? Are they a diabetic, and do they wear diabetic shoes? And how often do they wear them? If the patient is presenting with a sore on their buttocks, perhaps it's a pressure ulcer, and do they use pressure reduction devices like a wheelchair cushion and or any type of device on their mattress? And then have they used any adjunctive modalities such as hyperbaric oxygen, again arterial or edema type pumps, growth factors, bioengineered tissue, any modality to try to get this wound healed, and has it worked, has it not worked? And then what surgeries has the patient had related to this wound? Not all surgeries, just related to this wound. So for instance, did they just have the right leg revascularized 3 weeks ago and you're seeing them for a right foot ulcer? Also part of history of present illness is the assessment of pain. And this is where you want to note the location of the pain, the quality of the pain, the severity of the pain on a scale of 0 to 10. And then you want to note modifying factors, things that make the pain worse, things that make the pain better. And when we talk about leg ulcers, you want to note, for instance, does the patient have more pain with leg dependence? And is the pain relieved with leg elevation? Maybe it's a venous problem. Or maybe the pain is worse with leg elevation and better with leg dependence. That could indicate an arterial problem. You also want to do a review of systems, which is just a general inventory of the patient's body systems, looking for anything that might have been missed in the history of present illness and or in the past medical history. And this can be things like recent weight gain, weight loss, fever, chills. And the review of systems as well as the past medical history can be captured on a form that the patient fills out before they see you, and then you review that with the patient. Regarding past medical history, you can do a global past medical history, again, on that intake form. But in terms of wound healing, we want to look for things specifically that can either cause wounds or result in delayed wound healing, like diabetes, peripheral arterial disease. I'm very interested if a patient has a history of an MI or a stroke, because atherosclerosis is a systemic disorder, and if they have cerebrovascular or cardiovascular disease, they may also have peripheral arterial disease. Does the patient know they have chronic venous insufficiency, or have they had a history of a deep vein thrombosis? Do they have musculoskeletal or neurological disorders? Have they had any previous surgeries? And this is any type of surgery, not necessarily related to the wound, or any traumas. For instance, the patient that was in a car accident and broke their ankle and had an ankle fusion and now cannot move the right ankle, resulting in edema and poor calf muscle pump function. You want to know about autoimmune disease, liver disease, any chronic infections such as hepatitis or HIV. Again, anything that potentially could interfere with wound healing. And then you also want to look at current health status. So this is things like looking at the patient's medications that they're on, looking at their allergies. Do they smoke or have they smoked? Use of alcohol and or illicit drugs. You want to look at family history, and again, focusing on those things that can be inherited, that can lead to wounds or result in delayed wound healing. And then you want to look at social history. Does the patient have adequate social support? Who do they live with? What do they do for a living? What do they do for fun? And how does the wound impact their work and or their fun? And then whether a wound is acute or chronic is mainly determined by history. It's really how long has the wound been there? And that leads us to our first question. Which of the following is indicative of an acute wound? A, has a limited pro-inflammatory stimulus. B, present for weeks to months to years. C, is a one-time or repeated injury. Or D, fails to progress through normal phases of wound healing. When we look at acute versus chronic wounds, acute wounds have a limited pro-inflammatory stimulus. There's a one-time injury. That could be a traumatic injury. It could be surgical. And then the wound progresses through the normal phases of wound healing: inflammation, proliferation, and remodeling. Most of these wounds are going to be healed within 3 to 4 weeks. This is a patient who's healthy, who has no comorbidities or minimal comorbidities to interfere with wound healing. Chronic wounds, on the other hand, have a prolonged inflammatory stimulus. There may still have been a one-time injury or repeated injury, and the wound fails to proceed through normal phases of wound healing. And generally, these wounds get stuck in the inflammatory phase of wound healing, usually secondary to repetitive injury like repetitive friction, shear, pressure, increased bacterial colonization or infection, and or ischemia. And again, they get stuck in this inflammatory phase of wound healing, and these wounds may be present for weeks to months to years. So these are examples of acute wounds. On the top left, you have a patient with a full thickness avulsion injury that occurred about 10 days prior. You can see where the sutures are still intact, and part of the flap has survived and part of the flap has necrosed, but that is still considered an acute wound. Below that is an acute skin tear from that day the photo was taken. And then to the right, we have an acute blister that has been deroofed. On the chronic wounds, there are 4 classic chronic wounds that we talk about. And on the upper left, we have a venous ulcer. In a clockwise pattern to the right is an arterial, also called an ischemic ulcer on that toe. Below this is a diabetic foot ulcer. And then in the bottom left is a pressure ulcer. Those are classic chronic wounds. There are other types of chronic wounds, though. For instance, you can have a postoperative wound that becomes chronic. This patient on the upper left had a knee replacement a couple months prior and has this chronic draining wound that probes directly to the hardware. So this is a chronically infected artificial joint causing a chronic draining wound. On the right-hand side, this is an elderly woman who had a very simple basal cell carcinoma resection. She was sent home with some Vaseline gauze and applied it to the wound and would change it about once a week. And months later, she has this very large, much larger than the original wound, exuberant wound that culture shows is infected with strep. And basically, this is a chronic wound because of local management. She wasn't changing the dressing often enough. There was too much exudate. There's heavy bacterial colonization and infection, leading to a chronic wound. Now, you may ask, is that more cancer? No, it is not. This is strictly from the inability to take care of her wound properly, which led to a chronic wound. So that's history, and next we'll get into physical examination. Now, you can do a full physical exam where you listen to the heart, lungs, do full neurological check, or it's also acceptable to do a physical exam on systems that are pertinent to wound healing. And today, for our purposes, we're going to be focusing on cardiovascular, specifically peripheral vascular exam, musculoskeletal exam, neurologic exam, and skin exam. So when we talk about cardiovascular exam, we're going to be focusing on both arterial and venous circulation. Now, I am very systematic in terms of my exam because I find that if I do not do my exams the same way every time, I'm busy and I will forget steps. So the first thing I do after I have done my history is I tell the patient that I'm going to lay them flat because I want to check their arterial circulation. So the first thing I do is I auscultate over the aorta, iliac arteries, and femoral arteries. And specifically, I'm listening for bruits. And a bruit sounds like this. And a bruit indicates turbulent blood flow. Now, a bruit, especially over the aorta, could indicate an abdominal aortic aneurysm, and if I suspect that, I will refer the patient back to the primary care provider for a workup of that. But commonly over the iliac and femoral arteries, a bruit indicates turbulent blood flow from stenosis, from peripheral arterial disease. So that's what I'm trying to identify. Next, I want to palpate the femoral, popliteal, dorsalis pedis, and posterior tibial pulses. And you would like to grade those on a scale of 0 to 4, with 0 being absent, 1 plus is diminished, 2 plus is normal, 3 plus is strong, and 4 plus is bounding. And you want to remember that when checking pedal pulses, you should be able to find a pulse within a couple seconds of checking for that pulse. If you have to hunt for a pulse on the foot for a minute, 2 minutes, and then you think you finally feel something, it's possible at that point that you're feeling your own pulse. So remember that if you can't find a pulse right away, there probably isn't one. Next, I recommend that anyone who treats patients with chronic wounds use a Doppler to qualitatively assess lower extremity blood flow. Now, ideally, you should use a Doppler with a speaker for 2 reasons. Number one, I don't like to blow out my ears by using the Dopplers that have a stethoscope-type ear apparatus. And also, I like the patient to hear their pulses. Ideally, you should also use a Doppler with a pencil probe, as shown in this photo. With a very narrow probe, you're going to have less of a chance of picking up extraneous sounds like venous sounds. And when you're using the Doppler, you want to use a Doppler with an 8 to 10 megahertz probe, and you want to angle the Doppler along the long axis of the artery at about a 45 to a 60-degree angle. At that angle, you will pick up the best sounds. Now, if you hook a Doppler, you have the Doppler probe on the artery, and you hook that up to a strip recorder, you will get a very typical waveform as shown on this slide in the bottom left corner. And the normal waveform, if you look at it, if you see it on paper, or if you're listening to it, is triphasic, meaning that there are 3 phases to that waveform. Now, I have labeled these 3 waves A, B, and C, but these are only for educational purposes. These are not normally called A, B, and C waves. So when you're looking at this, what you're specifically looking at is the A wave is the forward flow component of systole. So the left ventricle contracts and blood runs out peripherally. Now, with normal arteries, as the blood is flowing through systole, the vessel stretches slightly because the normal vessels are elastic. And when there's recoil in early diastole, there's a reverse flow component. So the blood goes out during systole and then reverses slightly with recoil, and that's the B wave that you see. That's called the reverse flow component of the waveform. And then with normal blood flow, the blood then in late diastole moves forward again. So it's forward flow, forward flow, triphasic waveform. And that's going to sound kind of like a galloping horse. Choo, 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 like that. Now, as a patient develops arterial disease, they lose the waveform in reverse order. So they'll lose the C wave, and the waveform becomes biphasic. In other words, there's two components of the waveform and two sounds that you will hear. And this will sound like this, choo-choo, 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 choo-choo. Now, just note that a biphasic waveform may be normal in some patients, and that if a patient is hot or vasodilated, they can lose that C wave and still have normal flow. So if you hear a crisp biphasic flow, may indicate mild arterial disease, but generally the patient still has adequate flow for healing to occur. As arterial disease worsens, the patient loses the reverse flow component, that B wave, and you only have the A wave. And this is a monophasic waveform, and it's going to sound like this. Or it can also sound like this. But there's clearly only one sound. And a monophasic waveform is indicative qualitatively of severe arterial disease, and definitely further testing needs to be done. I also need to give you the caveat that depending on how long you've been listening to pulses, your ears can fool you. And so if you're not sure about what you're listening to, you still need to get further testing done to assess arterial flow. Now, arterial ulcers present fairly classically. They tend to occur on the distal extremities. They have well-demarcated wound edges and tend to be deep with a pale or necrotic base. They look like someone's taken a melon scooper and just scooped out tissue. There is no granulation tissue in these wounds, and they tend to be very painful, especially when the leg is elevated or when the patient is sleeping at night. This pain tends to be reduced with leg dependence. Now, in these patients, you may also see, of course, the absence or diminished pulses. You may see thin, shiny, dry skin, thickened nails, absence of hair, or cooler skin temperatures. However, I want to warn you that you can have a patient with thickened nails and thin skin with normal arterial flow. So those signs are not very specific. You may also see dependent rubor, in which the leg turns a deep red color with leg dependence, and then with leg elevation, the leg becomes very pale. So this slide shows two patients with very typical arterial ulcers. On the left, you have a wound that actually probes to bone, and the key here is that the patient needs to be revascularized, and then any surgery that needs to be done can be done. On the right, you have a patient with severe necrosis from severe arterial disease, and that patient is actually approaching a below-knee amputation. The next slide shows two more patients with arterial disease. On the left, the patient had a toe amputation and then got pressure from the postoperative bandage on the side of the foot, leading to tissue necrosis. Unfortunately, the patient had very poor arterial flow, and their arterial flow should have been reestablished prior to the amputation. On the bottom right, this is a typical classic arterial ulcer. Again, deep, punched out, no granulation tissue, presence of necrotic tissue. And then on this next slide, you see the black toe, black great toe, in a patient who has stubbed their toe. And then, frequently what happens with arterial ulcers is that patients may have adequate blood flow to support the intact skin at rest. But once the patient gets an injury, they don't have adequate blood flow to meet the increasing metabolic demands of wound healing and the tissue necrosis. And then on the right here, you see an ulcer from shoe gear and, again, punched out, deep necrotic tissue. When we look at venous circulation, we're looking specifically for dilated veins and varicose veins, edema, hyperpigmentation of the skin, and lipodermatosclerosis. Now, we can classify venous disease, and in fact, the American Venous Forum posted a classification system called the CEAP classification system. This was published in the mid-90s, and it's used again to classify venous disease. This is based on clinical science, which we will review. It's also based on etiology, and etiology refers to whether or not the venous disease is acquired or congenital, and this is obtained through both history and ultrasound findings. The A stands for anatomic distribution, which just means that we're looking at whether or not the venous disease involves the superficial veins and or the perforating veins and or the deep veins, and this is based on ultrasound assessment. And then lastly, the P is for pathophysiologic condition, and this stands for whether or not the patient has, or the veins, have obstruction and or reflux, and again, this is determined through ultrasound. So let's go through clinical signs of venous disease. First, let's have a question. Question 2, which of the following indicates a Class 3 classification of chronic lower extremity venous disease? A, no visible, palpable signs of venous disease. B, varicose veins. C, edema without skin changes. Or D, telangiectasias, reticular veins, and malleolar flare. So in terms of the clinical classification of chronic venous disease, according to the CEAP classification system, a Class 0 clinical presentation has no visible or palpable signs of venous disease. Now you might say, well, why would you have a Class 0? This could be a patient, for instance, who on ultrasound has a deep vein thrombosis. So we know they have venous disease, but they have no clinical signs yet. In Class 1 disease, there's the presence of telangiectasias, which are the tiny red dermal veins less than 1 millimeter in diameter, and dilated reticular veins, which are also dermal veins, but they're blue, and they're 1 to 3 millimeters in diameter and non-palpable. When you have telangiectasias and dilated reticular veins below the malleoli, especially the medial malleolus, this is called malleolar flare. It's also called venous flare, and it's called venous flare sign, and it's pathognomonic for chronic venous insufficiency. Class 2 is the presence of varicose veins, which are subcutaneous veins that are palpable, and they're 4 or more millimeters in diameter. Class 3 clinical disease is edema without skin changes. And then in Class 4, you have skin changes ascribed to venous disease. So you may have pigmentation, as shown in this slide, where there's this hyperpigmentation or brown discoloration of the skin. This is from years of venous disease, where there's been chronic edema and leakage of red blood cells into the skin. And when the red blood cells die, they leave hemosiderin behind. And so that's hemosiderin staining. There may be dermatitis, and this is also called stasis dermatitis. And this can be a rash, maculopapular rash, with itching and flaking skin. Remember that chronic venous insufficiency is an inflammatory condition, and so it's very common to have dermatitis in these patients. You may see atrophy blanche, which is a descriptive term for ivory-colored stellite scars on the legs. These wounds tend to be very painful, and they tend to be resistant to healing as the tissue is very atrophic. And then you may see lipodermatosclerosis, lipo meaning fat, dermato meaning skin, sclerosis meaning hardening, so hardening of the fat and skin. This kind of upside down champagne bottle look to the leg, where the lower leg is so fibrotic it can't even swell anymore, but you may have pitting edema above the area. End stage result of venous disease. Class 5 is skin changes with a healed ulcer, so we have a scar there from a previous ulcer. And Class 6 are skin changes with an active venous ulcer. So how do venous ulcers present clinically? Well, they tend to occur on the lower calf. They have irregular wound edges as opposed to the arterial ulcer, which is more regular. Venous ulcers tend to be superficial. They can be partial thickness or they may be superficially full thickness, but you're not going to see deep structure exposure with these. You're not going to see tendon. You're not going to see bone. And if you do, something else is wrong. They tend to have ruddy granulation tissue. You're not going to see necrotic tissue in these wounds unless the patient has coexisting arterial disease or if the wound was the result initially of a traumatic event and the necrotic tissue from the trauma hasn't been debrided yet. These patients tend to have increased pain with leg dependence that feels better with leg elevation. And these wounds tend to have a lot of exudate. I always tell patients that fluid follows the path of least resistance. So if they have an open wound and a lot of edema, that edema fluid is going to come out through the wound. And one way that I can tell that I've got their swelling really well controlled is that their exudate starts to decrease. This is a typical venous ulcer, irregularly shaped, superficial, ruddy granulation tissue surrounded by hyperpigmentation and varicose veins. Another venous ulcer here covered with a layer of fibrin, irregularly shaped, superficial, and this is the same wound a week later, and it's been debrided. We've put some compression on this leg, and we're starting to get some healthy granulation tissue. This is a close-up of a venous ulcer, and you can see those white dots in the wound are islands of epithelial tissue where the wound is epithelializing from the hair follicles. Again, this is a superficial wound where the bases of the hair follicles may still exist. So that's circulation. Next, we want to move on to musculoskeletal status, and we want to look at the patient's overall gait and station. For instance, are they ambulatory? Do they walk down the hallway to your clinic, or do they walk around their home if you're in the home situation, or if you're in the hospital, are they walking the halls? Do they use an assistive device? Do they activate the calf muscle pump with walking? In other words, do they walk heel, toe, and pump that fluid out of the leg? And then what is their ability to transfer to the exam table and reposition themselves? Patients that can't reposition themselves on the exam table may not be able to reposition themselves at home and may be at risk for pressure ulcers. You also want to look at joints, bones, muscles for malalignment, asymmetry, deformities, range of motion, stability, and look at muscular strength and tone. Specifically, I want to focus on foot deformities because this is typically what you will see in the diabetic. And the upper left-hand corner photo is classic diabetic foot with a high arch, very prominent ball of the foot. The ball of the foot is called the metatarsophalangeal joints, and then these cocked up claw toes. And so that particular patient, when they walk, they put all the pressure on the forefoot under those metatarsophalangeal joints. To the right of that is a Charcot foot where the arch has collapsed. And then the right lower wound is a classic diabetic ulcer on the tip of the great toe. You can see that right there, that little ulcer on the tip. That's a hammer toe deformity. And diabetics also tend to get very stiff metatarsophalangeal joints. They don't bend correctly. So that particular patient, when they walk, when they push off, they put all the pressure on the tip of that great toe. And then the bottom left-hand wound, you can see the callus on the tip of the second toe. That's a claw toe deformity, like the claws of a cat. And again, when that patient pushes off, they put pressure in that area, causing callus formation, and then the pressure from the callus leads to an eventual diabetic foot ulcer. On the neurologic exam, you want to check for loss of protective sensation from peripheral neuropathy using a 10-gram monofilament, also called a Semmes-Weinstein monofilament. You want to check for vibratory sensation using a 128 Hertz tuning fork, and then you want to check for deep tendon reflexes. Now, the combination of the neurological exam and the musculoskeletal exam brings us into a discussion of diabetic foot ulcers because you will see, again, deformities as well as neuropathy in these wounds. So let's talk about those for a few minutes. Diabetic foot ulcers classically occur on the plantar surface of the foot. They tend to be moderately deep with a round base, and granulation tissue tends to be present unless you have coexisting arterial disease or a significant infection. These wounds tend to be surrounded by callus, and in general, they tend to be painless because of the peripheral neuropathy. And in fact, if a patient comes to me with a diabetic neuropathic ulcer and they suddenly have a lot of pain, I get very worried about potential deep space infection because generally these patients don't have pain. So if they suddenly have pain, you have to look for a reason for that severe pain. So these are some classic presentations of diabetic feet. On the left-hand side, you have a patient with very prominent first, second, and fifth metatarsophalangeal joints. So that's where he gets the pressure. So when he walks, callus forms as a result of the repetitive trauma. And then the pressure of walking on the callus causes bleeding under the callus, and that's what that brown discoloration is. If we don't get the pressure off this patient, he's going to ulcerate. On the right is a classic diabetic foot ulcer under the third MTP joint. And then both of these wounds are located under the first MTP joint, again, metatarsal phalangeal joint. And you can see how both of those joints are prominent. Where the pressure is where the callus forms and where the wound occurs. These are both pictures of Charcot feet. And again, wherever the pressure is where the callus forms and the ulcer forms. Next, let's look at the skin. So we've assessed the wound. Now we need to look at the surrounding skin. And of course, you're going to measure the wound in terms of length times width times depth. But then you're going to look for other issues as well. And we'll go through each one of these. First, undermining. Undermining is where you have a ledge of skin with dead space underneath. And in this particular photo, this is a patient with an abscess on his shoulder. And you can see that ink mark is where the patient has undermining. It's important to know about undermining because that's really the true wound size, and you need to monitor that in terms of wound healing, but also know that if undermining is present, that area is going to need to be packed. You can also have undermining of just a couple millimeters, and in both of these wounds, these are patients with pyoderma gangrenosum, which typically has 1 to 2 millimeters of purple undermined borders. On the right, that's a peristomal pyoderma gangrenosum, and that thin bridge of skin across the middle is actually undermined. Granulation tissue formation is extracellular matrix, new blood vessels, and the cells involved in wound healing. And when you have healthy granulation tissue, as we do in both of these wounds, you actually have a wound that's proliferating and healing. You can also have abnormal granulation tissue, though. In both of these photos, we have exuberant granulation tissue formation. On the left, this is a patient with chronic lymphedema that is well controlled with compression therapy, and he presents with this exuberant wound that looks abnormal to me. So I biopsied it, and it was a basal cell carcinoma. On the right, this is a patient who had had this ulcer on the back of the upper arm for months and months, and it kind of has a fungating appearance, again, where it's growing over the level of the skin. It's exuberant. It's friable. I don't try any wound care on this patient. First, I biopsy it the day I see it, and again, it's a basal cell carcinoma. What about this patient, though, with friable granulation tissue? This is a patient with a wound on the anterior tibia. He's had it for a couple years. He has obvious venous disease with hyperpigmentation, edema, varicose veins. He has good arterial flow. You know, there's nothing wrong with me starting. I just thought this was a venous ulcer. We'll start him with some compression therapy, and in a month, he's no better. Well, after a month, that's my cutoff. I biopsy, and indeed, this came back a basal cell carcinoma. Now, this is a patient who was an elderly woman in her 80s who had had a long-standing pressure ulcer on her tailbone. And when she came to me with this ulcer, what concerned me was this exuberant, and it was also friable granulation tissue in this wound. It just kind of looked funny. And then she had that lumpy area off to the left. You can kind of see that in the light. And I just had a bad feeling. And I always say to people, trust your gut. And I had a bad feeling about this. And so in her case, I didn't do the biopsy. I sent her to dermatology. They biopsied it, and it came back with an aggressive form of squamous cell carcinoma. And this is actually a Marjolins ulcer. A Marjolins ulcer is the malignant transformation of a chronic wound or burn scar. And so in this case, this lady with this chronic pressure ulcer developed an aggressive form of skin cancer. These Marjolins ulcers are poorly differentiated and tend to metastasize quite readily. Now, there's also lack of granulation, as in this patient that has an arterial ulcer where, yeah, there's some eschar, some slough, some necrotic tissue, but you also see that pale pink tissue. That is not granulation tissue. That's just pale pink tissue. Moving on, this is a slide that shows eschar. And eschar is necrotic tissue that's dry. I frequently tell patients it's like shoe leather, versus this is the same wound about 8 days later. After sharp debridement and use of an enzymatic debriding agent, the eschar is gone, and now we see the starting of some granulation tissue as well as slough. And slough is that yellow, wet, adherent necrotic tissue. It doesn't scrape off. You have to cut it off. Now, every speaker has their one slide where they say, this is the most important slide of the presentation, and this is my slide. It is critical when you see dead tissue in a wound that you always ask the question, why has tissue died? Because if you don't, every once in a while you're going to miss more atypical causes of tissue death and may treat the patient inappropriately. So there are very common causes of tissue death, and there are more uncommon causes. So pressure ulcers, that's pretty easy for everyone. Pressure ulcers cause tissue necrosis from occlusion of blood flow due to pressure, and they tend to occur on bony prominences. Trauma. On the left, this is a patient who fell and had a severe full-thickness avulsion injury, and the flap of skin, although they tried to suture it down, it necrosed. On the right is a patient who fell and developed a severe hematoma on the calf, and the hematoma itself was a physical barrier to blood flow, and so the tissue above the hematoma necrosed. So this is tissue death secondary to trauma. You can also have tissue death from surgical trauma in a patient that had a breast reconstruction surgery, and the part of the flap has necrosed due to lack of blood flow. You can also have patients that have necrotizing infection in which the infection itself leads to tissue death. And then, as we've already said, you can have patients with peripheral arterial disease, macrovascular disease from atherosclerosis that leads to impaired blood flow, tissue ischemia, and tissue death. Those are all common causes of tissue death and what we most commonly see in wound care. But you have to be prepared that if you've ruled out those 4 common reasons and you have a patient who presents with dead tissue, that it could be a more atypical cause of impaired blood flow from impaired microvascular flow. So this is some type of occlusion occurring in the skin. This could be from vasculitis, which is an immune-mediated destruction of the vessels. It can occur in any vessel size, but for our purposes, generally we're talking about destruction, inflammation, and destruction of the dermal vessels, leading to tissue ischemia and tissue death. It could be vasculopathy, which is from blood clots forming in the dermal vessels, and this is related to hypercoagulable disorders. It could be microemboli, where the patient is showering the distal extremities with cholesterol crystal emboli or small, tiny clots following, for instance, a cardiac cath, and the clots get stuck in the dermal vessels and lead to tissue death. So if you have ruled out the common causes, you need to then assess for more uncommon causes of tissue death. Now, moving on to exposed structures. If there are exposed structures, it is very obviously on the left-hand side is a patient post-transmetatarsal amputation. On the right is a patient who had their great toe amputated, and that's the tip of the metatarsal sticking out there looking at us. As wound specialists, we have to know when there's nothing we can do, when the patient needs a surgeon and needs to be referred back to surgery for further care. We also have to be aware of the potential for exposed hardware or other prosthetic devices where, again, there's not a whole lot we can do from a wound standpoint. This is a patient who is with a wound above the medial malleolus who had this wound for about 3 to 4 months following an open reduction internal fixation of an ankle fracture. And this particular wound would come and go. It would heal over, then it would swell out, burst, drain pus, heal over, and that pattern continued until she came to the wound clinic. This wound probed directly to the hardware. Very simple treatment. Goes back to ortho, has the hardware removed, and the wound heals. This is a patient who was sent to me with an abdominal wound with mesh exposure following a hernia repair surgery. There is nothing I can do for this patient. I called the surgeon and said, you need to remove the mesh. There's nothing from a wound healing standpoint we can do, but we have to recognize in our assessment of what we're seeing and then help the team to develop a treatment plan. Moving on, still looking at the wound bed, we're talking about fibrin now. Now, fibrin is a gelatinous material. It's almost like a moist blood clot without the red blood cells. So it's wound fluid that has polymerized across the wound bed. This is easily curetted away, unlike slough, which has to be cut away. This brings us to question 3. The blank classifies diabetic foot ulcers by grade, ranging from grade 0, no ulcer, may have deformity, to grade 5, extensive gangrene involving the whole foot. This is either A, Wagner ulcer grade for diabetic foot ulcers, B, University of Texas Diabetic Wound Classification System, C, NPUAP Pressure Ulcer Staging System, or D, Partial Thickness/Full Thickness Rating Scale. So let's look at classification systems for depth of tissue damage. We have these for both diabetic foot ulcers and for pressure ulcers, or you can just classify wounds as partial or full thickness. I'm not going to be going through these classification systems in depth. However, I want to encourage you to go online or go to your library and get these classification systems and review them for yourself. I just want you to be familiar with them. So this shows the Wagner classification of diabetic foot ulcers, and it's a grading system from 0 to 5 that goes from having no ulcer with perhaps a deformity all the way up to it increases with tissue depth, and then as the grade goes up, you add in osteomyelitis or abscess or even gangrene. With the University of Texas Diabetic Wound Classification System, they're looking at grade involving either a superficial wound or a very deep wound, or stage involving either no infection or ischemia, infection, ischemia, or infection and ischemia. So for instance, if you had a grade 2C ulcer come over to grade 2, and this would be a wound penetrating to the tendon or capsule, and then come down to C with ischemia. So grade 2C ulcer is a wound penetrating to tendon or capsule with ischemia. The National Pressure Ulcer Advisory Panel is the gold standard for staging pressure ulcers. This is a 1 to 4 scale, and again, I want to encourage you to go to their website to review these in depth. The main points that I want to make is that a stage 1 pressure ulcer is a partial thickness problem, non-blanchable erythema of intact skin. Stage 2 is also a partial thickness problem with damage to the epidermis or part of the dermis. And what's key here is that stage 2 ulcers are shallow and clean and pink. With a stage 3 ulcer, you now have full thickness tissue loss. And this is going into the subcutaneous tissue but not beyond. Key here is that once you start with a stage 3 ulcer, that's where you may start seeing necrotic tissue, eschars, or slough. In a stage 4, this is also full thickness tissue loss, but now you have deep structure exposure such as bone, tendon, or muscle. And you will frequently see slough or eschar. Now the NPUAP also has added in the classification of unstageable, meaning that the wound has full thickness tissue loss, so it's at least a stage 3, possibly a stage 4 ulcer, but we don't know for sure how deep it is because the wound is filled with either slough or eschar. That has to be debrided before we can stage the ulcer. And then they also have added in something called suspected deep tissue injury. And this is where the skin is intact, and so someone might call it a stage 1, but there's a deep purple or maroon localized area of intact skin, which down the line, a week later, is going to end up necrosing and being an eschar. So this particular definition was brought in to recognize the difference between simple non-blanchable erythema and that patient that has intact skin, but it's deep purple and you know that it's already necrosed. And then you can classify wound depth as partial thickness or full thickness. Partial thickness is just damage to the epidermis and or part of the dermis. What's important about partial thickness wounds is they heal strictly from reepithelialization, versus full thickness wounds involve damage through the skin to the subcutaneous tissue and also possibly into deeper structures. These wounds heal by granulation tissue formation, wound contraction, and epithelialization. So that's wound bed. Now let's talk about skin, and specifically the surrounding skin, and we'll go through each one of these particular definitions. Erythema, redness of the skin. And generally, it indicates some type of inflammation and frequently indicates infection. So in the upper wound you have, or the upper photo, you have a wound with localized erythema, a localized infection, versus the lower photo is of a significant cellulitis. And whereas the upper wound might be treated as an outpatient, the lower wound patient is going to need to be hospitalized. Now we can also classify infections as non-limb and limb-threatening infections, and generally a non-limb-threatening infection is going to be considered to be a wound with and this is usually referring to diabetic foot ulcers. A non-limb threatening infection is going to be classified as having less than 2 centimeters of cellulitis, no deep space abscess or osteomyelitis, and no systemic signs of infection, such as we see in both of these photos. Whereas with a limb-threatening infection, now you have more than 2 centimeters of cellulitis. You might have a deep abscess. You might have osteomyelitis. Patient may have coexisting peripheral arterial disease and may have systemic signs of infection. Now, a caveat there. With diabetics, it's classic that they could have a limb-threatening infection and not have a fever and not have an elevated white count. And in fact, the only thing you might see is maybe slight increase in neutrophils on the differential and or an elevated SED rate. So it's important, for instance, on this particular slide on limb-threatening infection, this is a patient that had a wound on the plantar surface of his foot that probed all the way to the dorsal surface of the foot. And you can see the erythema on the dorsal surface of the foot. If you have a patient with a plantar ulcer and dorsal redness, that is a limb-threatening infection, and that patient needs to be hospitalized. When you add in peripheral arterial disease, these infections can be more serious. This is a patient that had an ulcer on the lateral side of the heel that's obviously necrotic with significant redness. And when you look at the medial side of the foot, he's also red on the medial side of the foot. This is a limb-threatening infection. The patient needs to be hospitalized. Now, rashes can occur for varying reasons, and in wound care we frequently see them because patients react to the products we use. So on the left-hand side is a patient with a pressure ulcer over the thoracic spine, and a hydrocolloid was being used, and the patient has a contact dermatitis from the hydrocolloid. On the right-hand side, you have a patient with a healing leg ulcer who's been treated with a paste bandage, also called an Uniboot. And she comes in one day. We've been using the Uniboot on her for a few weeks. She's been doing beautifully, and all of a sudden she's itching like mad. We take the Uniboot off, and she's got a well-demarcated rash. Although she was not initially allergic to the Uniboot, she has become sensitized and is now allergic and has a contact dermatitis. Calluses, we kind of talked about that before. This is a very typical plantar ulcer on a diabetic who's had a transmetatarsal amputation, and very common to see that surrounding callus. Now, this is subcallus bleeding. So let's say you take that diabetic and you're treating them appropriately by off-weighting them. And they're using crutches, a wheelchair, and an off-weighting device. And they say they're staying off their foot. Now, the patient will continue to form callus for weeks after you off-weight them, just simply because the keratinocytes are revved up and they've been forming callus. And it's going to take a while for that to calm down. But if they have subcallus bleeding, like in this photo, that is from shear and pressure, and that means the patient has been walking. So you see subcallus bleeding, you know that they have not been off-weighting. And then when you see calluses, they need to be debrided to identify whether or not the patient has an underlying wound. As you can see in this case, on this transmetatarsal amputation site, there's a callus, and when we debride the callus, there's an underlying wound. Purpura. Now, purpura just means bleeding into the tissue, and you could have very simple purpura, just like this, also called a bruise, from a patient who fell and they bruised their leg. Or you could have purpura like this. In a patient whose natural skin color is that lighter skin tone that you see on the dorsal surface of the foot, but he has multiple purpuric macules across his leg that have coalesced on the skin. And this is from cryoglobulinemia. This patient actually has a vasculitis from the cryoglobulinemia related to his hepatitis C. This is palpable purpura. Now, this is classically seen in vasculitis affecting the dermal vessels. So again, vasculitis is the immune-mediated destruction of the vessels leading to bleeding into the tissue. Now, these papules are palpable because of the local inflammation from the immune response. Then the purpura is from the vessel destruction and bleeding into the tissue. So this is palpable purpura. This is purpura and necrosis, again from a dermal vessel problem on the upper left. Those areas of purpura are from a patient who is showering the lower extremities with cholesterol crystal emboli from a proximal aortic aneurysm. And so those cholesterol crystals get lodged in the skin and cause tissue necrosis and ulcers. On the bottom right, this is a patient with leukocytoclastic vasculitis, as we've previously discussed, and this was from simply a drug reaction from the naproxen that the patient was taking for his osteoarthritis. Maceration is just the overhydration of the skin, and generally it indicates that the exudate is not being well managed, and so we need to, this assessment finding lets us know there's a lot of exudate. We need to control edema to try to decrease that exudate, and also change the dressing more frequently and change what we're using on this patient. Hyperpigmentation seen in venous disease, we've already discussed that. And then livido reticularis is a net-like discoloration of the skin, and it basically indicates some interruption in dermal blood flow. Now, livido reticularis can be a normal finding. In the wintertime, if I'm cold enough, I'll get some livido reticularis on my legs. But if you see this in a patient that has necrotic ulcers on their legs, it could mean that there's a dermal problem, a vasculitis, a vasculopathy, or cholesterol crystal embolization. This livido reticularis is seen in 90% of patients presenting with cholesterol crystal embolization. Next, you want to look at wound location. This brings us to question 4. A blank ulcer may present at any location on the leg. A, arterial, B, venous, C, neuropathic, D, pressure. So the location can help you determine etiology. This is not cut in stone, but it does help. So for instance, an ulcer on the lower calf may be a venous problem. On the distal foot may be an arterial problem. On the plantar foot may be a neuropathic problem. On a bony prominence, such as the heel, ankle, hip, or sacrum, could be a pressure problem. But these etiologies can be coexisting, and remember, especially arterial ulcers may be at any location on the leg. Also, the location of the wound can clue you into the fact that the wound in an unusual location could be from an atypical diagnosis, or the diagnosis may require more in-depth questioning about the history. So you've done a full history, and then you look at the wound and you say, I don't know what this is. I need to ask more questions. So this particular patient, who is in his mid-50s, healthy guy, presents with a 6-month history of this wound on his inner thigh. He has no reason to have this wound. There's no underlying pathology that we can determine as to why he has this wound that is gradually getting larger. We're not going to try some kind of new dressing on this. We're going to biopsy it that day. This is a squamous cell carcinoma. This is a patient who presented to me a few years ago with a 2-year history of this expanding ulcer on her medial thigh. Started out as a painless nodule that gradually got larger, no pain the first year, and at this point she's having significant pain in the area, most likely due to the fact that she has significant edema and lymphedema at this point. She had been to dermatology, who biopsied it, found nonspecific findings, and diagnosed her with pyoderma gangrenosum. She was started on prednisone, given a prescription for cyclosporin, and sent to me for wound dressing recommendations. Now, I looked at this wound, and first of all, I did not feel that it looked like a pyoderma gangrenosum, but also pyoderma gangrenosums hurt. And so, in my opinion, going a year with no pain kind of clued me in that I wasn't sure it was a pyoderma. So I wasn't sure what it was, so I did more biopsies. I did 3 biopsies, 1 from the edge, 2 from the center, and sent them for histology, atypical cultures, fungal cultures, and the biopsy came back cutaneous lymphoma. So I think what's really important here is to not always accept the diagnosis that a patient comes in with. Be thinking yourself of what else it could be. Sometimes you don't know, like I didn't know, and then get more biopsies. Now, this is a patient where you see the wound and then you have to ask more questions. On the history and referral, this was a history of multiple abscesses in the groin area. The patient had had multiple incisions and drainages, and nobody seemed to understand why he kept getting these wounds. And so I just expected to see some classic, ulcers from abscesses. But when I looked at these wounds, what did I see? I saw wounds, especially the one on the his left medial thigh, with very thickened hyperkeratotic edges. And in my experience, when I see that, that is a result of repetitive trauma. So I asked the patient, can I look at your arms and your back? We took off his shirt, and he had multiple scabs and scars from previous ulcers. And so I said, do you ever pick at your wounds? Constantly. These wounds were the result of picking. They weren't the results of multiple abscesses. These were from him picking chronically. And when we covered the wounds up, the wounds healed. So you've done your physical exam, and now based on your physical exam, you're going to decide whether or not you need to get any investigational studies. So you may need to get further vascular studies, radiologic studies, or lab studies. I'm going to concentrate on vascular here, and I want to mention from a radiologic standpoint, one thing I do routinely is when I have a patient with a diabetic foot ulcer, we always get baseline x-rays of the foot, not only to look for any bony abnormalities, but to also have baseline films to compare films in the future, especially if the wound deteriorates. So if you have a patient where you suspect arterial disease because of your exam and you want to quantify that, you will order non-invasive arterial testing. And in general, what you will get is Doppler waveform analysis, segmental pressures, toe pressures, and color duplex imaging. The transcutaneous oxygen monitoring and the skin perfusion pressure is mainly done in specialty clinics, hyperbaric centers, and wound clinics. So when you order testing, you're going to get the top 4. So I'd like to talk about those. We've already explained what you'll see with a Doppler waveform analysis, but with the next slide, I want to actually show you what 3 waveforms look like. Now, it's important when you're looking at Doppler waveform analysis is that you always find the baseline, and the baseline of the waveform is going to be noted right before the systolic component, right before that first forward flow component. So on the left-hand sided graph, we find baseline, and then you can see forward flow, reverse flow, and forward flow before the waveform returns to baseline. And that is a triphasic waveform. In the upper right, you find baseline right before the forward flow component, and you can see forward flow and reverse flow, but it never returns to baseline again before it goes into the next cycle. So that is a biphasic waveform. And then on the bottom right is a monophasic waveform. Segmental pressures can give you information, again, functional information about blood flow, and also help you see where narrowing or stenosis may occur. For instance, segmental pressures are done at the high thigh, low thigh, high calf, and ankle. If you have a systolic pressure at the high thigh of 170 millimeters mercury, and at the low thigh it's 100 millimeters mercury, that tells you that there's some type of narrowing in the superficial femoral artery. So any gradient greater than 20 millimeters mercury indicates some type of occlusion between the 2 cuffs. Also, when you do segmental pressures, you're going to get ankle brachial indices. And ABIs are where you take the ankle pressure, and that's divided by the brachial pressure, and you end up with an index. Now, normally, the ankle pressure should be the same or slightly higher than the brachial pressure. The way I explain it to patients is I say your ankle pressure should be 100% to 120% of whatever your brachial pressure is. That brings us to question 5. Which of the following measurements on the ankle brachial index indicates severe arterial occlusive disease? A, greater than 0.1, B, less than 0.5, C, greater than 0.75, D, greater than 1.0. So when you look at normals on ABIs, normal is greater than 1 up to about 1.2, 1.3. Once you get an ABI above about 1.3, you have to start thinking that you might be getting falsely elevated ankle pressures due to medial calcification of the arteries. In other words, because of severe arterial disease, especially in the very elderly, diabetics, and patients with renal failure, the vessels become like lead pipes and they're non-compressible. So you can pump the cuff up to 250 millimeters and still hear a pulse. So if you have falsely elevated systolic pressures, you'll have falsely elevated ABIs, and the ABI cannot be used to assess arterial flow. But if you have compressible vessels, then anything below 1 is considered abnormal, and as you get below 0.5, you have severe arterial occlusive disease. Toe pressures can be done. In general, the digital arteries are not affected by medial calcification. They can be, but that's unusual. And so when you can't get an ABI, you can do a toe pressure to assess peripheral flow. And in this case, a small cuff is put on the toe. A photoelectrode is applied distally to watch for blood flow, and then the cuff is inflated. As the cuff is then deflated, the minute that the photoelectrode senses blood flow, that is your toe pressure. And generally, toe pressures less than 30 millimeters mercury are indicative of poor potential for wound healing. Color duplex scanning really is the gold standard for assessing arterial flow non-invasively, and this gives you anatomic as well as physiologic data regarding blood flow. Above you see the actual scan, and in this case it's labeled generally arterial flow is forward flow or distal flow, whereas blue flow is reverse flow. And in this particular case you have an open vessel, and then down below you have a triphasic waveform. Here you have a duplex scan showing turbulent blood flow within a vessel. That's an area of stenosis and monophasic waveforms. Now, what's important about non-invasive vascular testing is it gives you functional information about how your patient is doing in terms of blood flow. For instance, you could have a patient with a significant stenosis of the femoral artery, but if they have enough collateral blood flow to have an ankle brachial index of 0.7, their wound may still heal. So that gives you functional information. Now, we can define critical limb ischemia, on the other hand, as persistently recurring ischemic rest pain requiring analgesia lasting over 2 weeks and or ulceration or gangrene of the foot or toes with an ankle systolic pressure less than 50 and a toe pressure and or a toe pressure less than 30 millimeters mercury. These are patients that you don't wait for the referral to vascular and the approval. You call a vascular surgeon. You want the patient seen that week. Otherwise, they're going to lose their foot. The vascular surgeon, after they do the non-invasive vascular testing, may decide to do an angiogram, and this is basically used as a map to plan the revascularization procedure. So when an angiogram is done, the decision is already made that, hey, we're going to revascularize if we can, based on the non-invasive testing. Venous non-invasive testing I'm not going to talk about, just to tell you that air and photoplethysmography gives you information about calf muscle pump function. The gold standard today really is color duplex scanning, but please note this. The typical ultrasound that's done over a 20-minute period in an ER looking for a DVT is not sufficient to look for venous insufficiency. The correct ultrasound that's done to look for venous insufficiency, reflux, and to map the veins to plan whether or not the patient is a candidate for some type of venous ablation is the standing venous ultrasound. And that takes an hour and a half to 2 hours and requires skill. So if you specifically, this is generally the patient is sent to a vascular surgeon, and then the vascular surgeon orders the standing ultrasound. But again, that ultrasound you order to rule out a DVT will not work to show you whether or not the patient has venous insufficiency. Laboratory studies should be considered for assessment of nutritional status, especially in patients with large ulcers like pressure ulcers, postoperative wounds. And then you may have to order other labs, especially if you suspect atypical wounds. And then lastly, I just want to mention that biopsy is critical for diagnosis if you suspect any type of atypical wound, such as a vasculitis, vasculopathy, inflammatory conditions, malignancies, or bullous disorders. And it's critical that the biopsy be done correctly. If you're ruling out a vasculitis or a vasculopathy, you've got to biopsy the newest purpuric lesions to see where the action is. You biopsy the wound, you won't get anything. On the other hand, if you're looking for cancer, you're going to biopsy the wound. So with a comprehensive assessment that leads to appropriate treatment, most wounds should improve within 2 to 4 weeks. Now, the signs of a responding wound, where you know that you're on the right path, is the wound edges are flattened with new skin forming, and that new skin appears as a light pink to lavender edge versus the wound that has a rolled, non-proliferative edge. You may see increased granulation tissue, decreased necrosis, and then decreased inflammation and pain. So this is a patient showing active epithelialization, where you can see over about a month's period, you have that nice pink lavender epithelium at the edges are flattened, and you're on the right path. If no response, you need to reassess. Is the arterial flow adequate? Is edema controlled? Is the wound infected? Is pressure relieved? Have you looked at underlying pathology and treated it? And then reassess the underlying problem. Is it really a venous or arterial ulcer? Is it maybe an atypical wound? Remember that leg ulcers from atypical etiologies can occur in up to 10% of cases. So in summary, a systematic approach that involves a thorough history and physical exam and appropriate investigational studies will facilitate a correct diagnosis and an optimal treatment plan. And I want to thank you for joining us today.